Now looking at the joints between the lower leg and the foot, we're going to move down into the foot and ankle region itself. Just a quick reminder, the skeleton of the foot comprises of at least 26 bones. We've got the 7 tarsal bones at the back, we have the 5 metatarsals, typical long bones, and then 14 phalanges, the 2 phalanges, proximal and distal phalanx in the big toe, and then 3 proximal, middle and distal phalanges in the other toes. And then in addition to that, we've got a variable number of sesamoid bones, plus occasionally anomalous bones, additional bones that have developed, things like accessory navicular bones or ostrigonums, which are bones that have developed. Now the reason we have this multi-segmented structure at the end of our limb is because the foot needs to fulfill 2 mutually exclusive roles. It needs to be mobile and adaptable in the early phase of the weight-bearing part of gait, so that it can act as a shock absorber and adapt to the surfaces, the terrain that it's walking on. And then it needs to be a solid lever for propulsion, a rigid lever for propulsion in the terminal phases of gait. And it does this by changing its position, by supinating and pronating the foot as a whole, to lock and unlock the joints. The joints of the foot are as follows. The first joint that we come to, when we get to the end of the tibia and fibula, we come to the ankle joint, which is anatomically known as the talocrural joint. It is a mortise and tenon arrangement with the talus, the top of the talus, slotting in between the mortise formed by the lower end of fibula and the lower end of tibia. It's inherently stable. It's a very solid joint. It's the architecture, the bony architecture, that makes this joint as stable as it is. So dislocation is difficult. It's not unheard of, but it is difficult. Fractures are more common in this region rather than dislocations. The talus is gripped by the 2 malleoli extending down either side of it, and this anatomical arrangement makes it into a synovial hinge joint, a typical synovial hinge joint. So it's a uniaxial joint that has a strong set of collateral ligaments. There are 3 articular surfaces that we need to describe that are continuous with each other. So when we look at the lateral side of the joints, the lateral aspect of the body of the talus, here we can see a slightly disarticulated ankle here. So there is a facet on the lateral side of the body of the talus which is triangular in shape, and there is a corresponding facet on the medial side of the lateral malleolus. On the medial side of the talus, we have this articular facet. This is a comma-shaped facet, often described as comma-shaped facet because it's a comma laying on its side. And again, this articulates with a corresponding facet on the lateral aspect of the medial malleolus. So they've got the 2 malleoli articulating with the comma-shaped facet medially and the triangular facet laterally. But on the top of the talus itself, on the top of the body of its talus, we have this pulley-shaped surface. So this is known as the trochlear surface. The term trochlear refers to a pulley-shaped surface. So the superior surface of the talus is convex in an anteroposterior direction, but concave mediolaterally. It typically looks like a pulley, and that articulates with a corresponding area, corresponding facet on the underside of the lower end of the tibia. It's the articular surfaces that provide inherent stability to the ankle, and it's also the shapes of the articular surfaces that often limit motion to the movements of dorsiflexion and plantarflexion. It's a typical synovial joint, so all of the articular surfaces are covered with hyaline cartilage that is continuous. Although we've described 3 different regions, it's a single joint cavity, and the 3 articular surfaces are continuous with each other. And just like any other synovial joint, the ankle joint is surrounded by a fibrous capsule, and the fibrous capsule does the same as any other fibrous capsule does. It extends beyond the articular margins proximally here, and it extends down to just beyond the articular margins on the talus, all the way around, except for anteriorly, where we've got these excessively long fibers that extend right down to the end of the neck of the talus. Now the reason we have these long fibers is to allow the movement of plantar flexion. So when the foot plantar flexes, the talus can move downwards and forwards. It can extrude forward between the malleoli, and the length of the capsular fibers permit this motion. The anterior part of the capsule is the weakest portion of the capsule and is probably the most commonly injured. But the capsule is lined with a synovial membrane, and the synovial membrane does everything that any other synovial membrane does. It attaches to the edges of the hyaline cartilage intra-articularly. It comes up and lines the capsule and covers any intra-articular bone. So the neck of the talus here, anteriorly in particular, is covered with a layer of synovial membrane. So we've got the synovial membrane going from the edge of the tibia on the inner surface of the capsule, comes back up before coming to the articular margin on the body of the talus itself. Okay, so we've got this extensive synovial membrane anteriorly, again to allow the movement of plantar flexion. It's a typical hinge joint, so we have two strong sets of collateral ligaments. On the medial side, we have four ligaments that when looked at on cadaveric studies or when the body's opened up, they don't look like separate bands. It looks like one large continuous structure. The collateral ligaments all arise from the malleoli. So we've got the medial collateral ligaments arise from the anterior, inferior and posterior surfaces of the medial malleolus. So here's the medial malleolus hanging down here. We've got the anterior ligaments coming from the anterior border of the malleolus, inferior ligaments from the inferior border, and then posterior ligaments coming from the posterior border of the malleolus. And they're named according to their attachment. So this green one that we have here is called the anterior tibio-talar ligament, passing from the malleolus, from the anterior border of the medial malleolus to the medial side of the neck of the talus. The brown one is the tibio-navicular ligament, going from the anterior border of the malleolus to the tuberosity on the medial aspect of the navicular. This is the tibiocalcaneal ligament, passing from the tip of the medial malleolus down to the length of the sustentaculum tali here. And then finally we have the posterior tibio-talar ligament, passing from the posterior border of the malleolus across to the medial tubercle of the talus itself. As I said, they're collectively known as the deltoid ligament because they form a triangular shape across the medial aspect of the ankle, and it's a very strong arrangement. It's a very strong ligament itself, the deltoid ligament is. The function of the deltoid ligament is essentially to prevent the movements of eversion, to stop the foot from being excessively everted away from the ankle. The anterior ligaments will be taught in plantar flexion. The posterior ligaments and the calcaneal ligaments are taught in dorsiflexion. The lateral aspect, on the other hand, is a far weaker arrangement. You've got three much smaller ligaments, distinct structures that don't blend together. So here we've got the smallest and more the thinnest, the anterior talofibular ligament. So passing from the lateral aspect of the neck of the talus to the anterior border of the lateral malleolus. It reflects very much what the tibio-talar ligament does, the anterior tibio-talar ligament. This is the weakest ligament, and it's the most commonly injured structure that we will come across. This green structure that we see here is the calcaneofibular ligament, passing from the lateral surface of the calcaneum, roughly around the level of the peroneal tubercle, up to the apex, the tip of the lateral malleolus, the tip of the fibula, the calcaneofibular ligament. And this little red structure that we see lying almost horizontally is the posterior talofibular ligament, passing from the posterior margins of the malleolus across to the lateral tubercle of the talus. Far weaker arrangement. Again, the anterior ligament is taught in plantar flexion. The calcaneal ligament limits adduction of the calcaneum or inversion, and then the posterior one is taught in dorsiflexion. Once again, these structures are named according to their attachment, so learning the names will actually help you work out where the ligaments go from and to. Now, in addition to the collateral ligaments, there's a number of thickenings in the capsule, anteriorly and posteriorly, and some texts refer to these as the anterior and posterior talocrural ligaments. There's debate as to their existence as ligaments themselves, or whether they are merely just thickenings in the capsule. The role of the ligaments is to prevent movement. The anterior ligaments, so the anterior talofibular ligament and the anterior tibiotalar and tibionavicular ligaments all are taught in the movements of plantar flexion. The calcaneal ligaments limit abduction of the calcaneus, and the posterior ligaments limit dorsiflexion, are taught in dorsiflexion. The ankle, however, is most stable in dorsiflexion. The body of the talus is wider anteriorly, so as we dorsiflex the ankle, the anterior portion of the body of the talus wedges itself between the tibia and the fibula. And as it wedges itself, the tib and fib separate ever so slightly at the tibiofibular joints. It's very stable in that position, and so injury of the posterior ligaments is not common. Its loose packed, on the other hand, is most unstable when the foot is plantar flexed. The posterior part of the body of the talus is narrower, and as the foot is plantar flexed, the talus itself can abduct ever so slightly. This is commonly the position of injury.